and start class today. Welcome to Pediatrics and congratulations for getting this far in the program. You are one semester away from capstone and graduating, so I know how difficult that is, so congratulations. This is a semester where you have 3 difficult courses all at the same time. You got Pediatrics, Med-Surg 2, and you have Community, and it is a lot of work to do. I really encourage you to be organized from the very beginning and to somehow set you up where you know what assignments are due weekly. I like to write it out on a calendar. Some students like to just take it, put on a spreadsheet, whatever works for you, just keep yourself organized. Because by the time you get to the end of the semester, it is going to get pretty crazy, okay? You're going to have assignments, projects due in peds, you're going to have assignments due in community, and of course, Med-Surg 2 is always really rough. So I highly suggest get organized and do not get behind at all. So my name is Professor Bogart, and I have been at Fortis. I was originally on ground. I taught pharmacology and I taught pediatrics. And when they went to an online program, I immediately went over. It was actually the reason why I went on in 2009. I went on to go to my higher level degrees because I knew that retiring was not a possibility because I didn't have all this extra money saved up and I didn't have a retirement because nurses don't. So I went on and got my higher level degrees, and right now I'm finishing my PhD in nursing. My dissertation is actually a pediatric one. It's school-age children's attitude and behaviors towards injections. Because we've done things to help children, but no one has ever, in all the research I've done, asked a child why they were afraid or why they weren't afraid. And school-age children are a great group of students to ask, and it's been proven through research that their input is really good. So COVID came, it hit me, and then I had to put it on hold, but you know, that is the dissertation. As soon as I can get it done, it will be done. I know what it's like for you this semester. I know it's going to be difficult. All I ask for you to do is to communicate with me. And, you know, let's say something's going on in your life, you can't get something done, you can't get some sort of assignment done, you know, please send it to me as soon as you possibly can. And communicate me before assignments are due, and I can help you. So our syllabus is our Bible, and make sure you follow the dates on the syllabus, which week, when things are due. They're actually the case studies, they will show that they're due a week later than what the syllabus is because we have to keep them open for those students who can't get them in on time. So make sure you follow your syllabus. And I will go over every week what is due. So this week you have discussion question number 1. I do read them. I like to know about you. I like to know what your input is and how you think about things. And I like the way you respond to other students. So be aware that I do look at those things. APA is important. I don't go crazy over exacting APA, but I want a good part of it. I want your resources put down in an appropriate way, and I want you to cite during your responses. Now, if you haven't done that, what I do is I will send you examples or tell you what you need in order to get a better grade. I mean, my goal is for you to succeed, and I'm here to help you. If you don't understand something, you ask me. I will answer those questions. So if you are doing a paper, you're not understanding something, you either text me, email me, and I will help you because I want you to be the best that you want to be, and I can help you succeed with those things. Now, let's say you're going on and you're doing an assignment, you're not understanding it, or you're having a moment and you need a quick response. You may text me on my personal cell phone. It is listed in the announcements, but it is also, I'm going to tell you now, it is 305 951-8055. Text me and I'll get back with you. But you will also notice I'm always checking my phone for messages. So I will respond actually pretty quickly. And I do respond over the weekend too. I know that sometimes that's when you can do things. And I also know sometimes it's, late at night. So as soon as I can respond to you, I will respond. I think that that's what you need from me. And that's what I'm going to do for you. I've been a nurse for 46 years. I have done peds and I have done adults. So as you go through Med-Surg 2, you're going to notice something. Peds and Med-Surg 2, the topics and diagnoses, they are going to be very similar week to week. So what I'll do for you is I will let you know what is specific to pediatrics and what is the same, whether it's an adult patient or a pediatric patient. So because of my experiences, I've done the adults and ICU and open hearts and telemetries and med-surg and emergency room. I have the understanding of what is similar to peds. Now in peds, I've done newborn ICU, cardiac ICU, which is actually my favorite. PD ICU. And the most recent one that I did before I left the hospitals was the emergency room at a very busy trauma center, level 4 trauma. So I was a trauma nurse there too. So I have a lot of experience to share with you and a lot of stories that I'm going to tell you that hopefully will help you understand what I'm talking about. So my phone number again is 305-951-8055. Now, what do I expect from you? I want you to be able to ask me before something is due, that you need extra time or something's going on in your life. I understand life happens. I get that. I mean, my life happens too. If beforehand you know you can't complete something, let me know and I can give you an extension. But if it's after the due date, I can do nothing. Okay. And I don't want to do that. I want you to have that ability to get that extra time sometimes when you need it. Now, not for every assignment, but things happen. And I've been doing online since it started. So, I know a lot of things, a lot of, situations that occur. So just let me know. So communication, number one, most important. Tell me beforehand, I can work with you. I'm very lenient as long as you tell me before. If you let me know after, there's nothing I can do. I can't, stop subtracting 10% because you were late, because you didn't hand it in. If you tell me before, depending on situations, I can help you there. The other thing I request is I want your cameras on. And the reason for this is I like to see your faces. And those faces can tell me when you're getting bored, when you're not understanding, when I'm talking and doing a lecture and all of a sudden you're zoning out. Maybe I can throw in a story. Maybe I can throw in one of my things that has occurred to me, one of my, patients that I've taken care of. And sometimes getting that, you're like, oh, okay, it's something about a child. Let me listen, I'll make it interesting. But if you are just a name, with a black screen, I don't know what's going on. The only time I don't want your screen on is if you're driving, okay? Classes are mandatory online, and if you can't attend, tell me before class is held that you can't attend. And if you can't, I will tell you a couple questions to answer, which you'll put on where the attendance attestation is, and just a couple questions about that lecture of the day to see that you did listen to the recording. I will post the recordings. I usually post these recordings by midday tomorrow. And I also will post the Kahoots that I do every single week. It is a YouTube channel, which I have developed. It is Professor Bogart's Pediatric Nursing. And you're going to see all of last semester's stuff there too. So you've got a lot of tools to use to help you succeed in this course. There are 3 exams. We give reviews for every exam. Each professor does a review. You may go to as many reviews as you want, and I do post all of those reviews. You will see them in your announcements. I will not overdo announcements. If I have posted announcements, it's something important. I'm not going to give you 5 a day. I'm not going to give you 20 a week. I don't believe in that. I think announcements are for those things that are important. I will tell you what we're going to do that week and attach the PowerPoint. I also will give you your recording and the Kahoots link, and then I'll give you the PowerPoint attached again. And then if it's something important, I'll send you an announcement. So if you see announcements from me, I know you're going to have 3 classes. You have a lot of stuff going on. Don't ignore my announcements because they're usually something important, okay? I don't believe in a lot of them. I think that's just makes you crazy and gets you confused, and I don't want that for you. So every week, what I'm going to do is you're going to get an announcement. You're going to get what's due. And you're also going to get, what the topic is with the PowerPoint. And what I want you to do is minimum do the interactive lecture, which is on your modules weekly before you come to class. Then I'm going to give you a PowerPoint and talk about it, trying to make it understandable for you. And when I'm done with that, I'm going to do a Kahoots. And the Kahoots are extremely important. I just don't take Kahoots, make questions that are random. Those questions, I have fine-tuned them to what questions you might see on a quiz, on an exam, on your essay, on your NCLEX, important concepts. And most of the questions I make up myself. So, and as I'm giving you the Kahoots, I'm going to explain it, show you how to answer it, why it was that question, what you needed to know, and what was the important thing. So Kahoots are a very important concept in my class. So you will be getting them posted every single week, and I review them every single semester. I look at past HESIs, I look at past exams, current exams, and I make sure that I have something there in these Kahoots to have you go back and look. If you don't understand when I'm talking about a concept, go back to your book and read about it. Make sure you understand it. There's application, there's understanding what a definition of something is, and then it's how do you apply it. If I talk about diabetes and I'm talking about ketones, and what does that mean? So, and I will, as I do Kahoots, try to open your minds to think a little bit more, okay? Make you think, critical thinking skills. I'll try to do that. And the way I teach very simplistically. I try to make it very understandable for you because I know it is rough. I know it's hard to wrap your mind around how to do things. Remember, I went through nursing school too. I remember it very clearly. I remember coming out of nursing school and not knowing what I was doing. But then I remembered somehow something in me said, okay, but why am I doing this? And this is before they had things like AdPi. I didn't understand what that meant, but just very naturally, I did it myself. But I'm going to try to make it simple for you too. Okay? Any questions? All right, so tonight we're doing 3 different things. I've given you an introduction. I'm going to be doing the PowerPoint of online program, the things about it. I'm also going to do a PowerPoint on an overview of pediatrics, and then I'm going to do a Kahoots for you. Hopefully tonight I'll be done right at 8 o'clock, okay? Most other nights I'm done about 10 till. Now, I don't give a break in between what I do. It's a 2-hour class. I go from the PowerPoint, then I go to the Kahoots, and I try to get it all fit in and get you out earlier. Is that okay with y'all? Okay, good. And remember, any questions that you have, I want you to stop me. Just say, Professor Boger, I don't understand. Can you explain that in a different way, a different term? I don't get it. and I will take my time to make you understand it. Now, you have a question, you don't know the answer, it's not a stupid question, okay? Because I always say there is no stupid question if you don't know the answer. And I'm sure somebody else doesn't know it also. So don't be afraid to voice and ask, okay? I do not mind, you're not rude, please stop me. So Jessica, Whitney or Itney, and Catherine, turn on your cameras for me, please. That's all I request. Come to class, be here with me. All right, let's go first over to our PowerPoint about online nursing and what I expect from you, so you understand what the expectations are. Number one, yes.
Professor, some of us have a class tonight at 8, so is it okay that we exit a little early?
Absolutely. If I always say, if I go over time, you may leave. And I understand you have other whatever, whether a class, pick up your kids, do something. I get that. That's okay with me. You do not have to explain that. If you're in class, you're on camera, you have to get up, go to the ladies' room, men's room, go. If you need to eat, please eat. I don't mind any of that, okay? Thank you for asking me that, because that was a great question. So online learning is just like a class, but I'm not there in the class with you. I'm giving you the same information that I would give if I was on ground teaching you in your colleges, okay? It is the same thing. So coming to class is mandatory. If you can't come to class, please tell me beforehand if you possibly can. And I will give you a couple of questions to do, as I just said before, and we can then sign the attendance attestations. Make sure that you have some sort of way to understand what is due that week. As I said, I'll go over it every week. I will tell you. You have a discussion question that is due, and it was due last night, and some of you didn't do it. Don't worry. I'm taking no points off. Nothing the first week. This is something that happens because you wait to come to class first. That's okay. All right. But just have it in by Sunday night with 2 peer responses. Okay. And make sure that you do have references of where you get some of this information from. When you have problems, contact me first. Okay. Now, if you are having problems with your computer, you're taking a quiz, exam, something, and your computer stops working, or there's an ice storm, or thunderstorm, and whatever, number one thing you need to do is stop, sign out of what you're doing, and send me a message in Canvas that gives me a timestamp that shows me what time it happened, because I can go back and look at times in your quizzes, et cetera, et cetera. So make sure you do that. Now, let's say something's going on, you can't do something, or you need explanations. First of all, you contact me. Now, I am the lead pediatric professor. So the next person you should contact, in case you need assistant, is the dean, which is the Dean Brown, Dr. Brown. Now, she is always available. I have never, ever had a moment where I couldn't reach her, whether it's morning, night, weekend, she's always available. And this is her phone number there. If she doesn't answer, leave a message. She does get back to you quick. I get back to you pretty quick. I mean, you have my cell phone number now. If you need something quick, I will respond. Send me a message. I answer messages really quickly, even on weekends, okay? So let me see. We know that each thing that is due starts on Monday at 12 a.m. or late Sunday night. And it goes through Sunday night at 11:59 p.m. by that specific time. If you're Eastern, that means 2:59. So make sure that you get things in on time. Now, again, Wednesday is the initial post. I did send some messages today just to let you know, okay? It wasn't there to say, you did bad, I'm taking points off. It's just to reinforce. It's due on Wednesday, and then Sunday, give me the other 2s. I'm very understanding of things. Again, if you can't do it from now on, send me a message. Let me know what's going on, okay? If you have work that's due, a case study, NCLEX, and you can't get it in on time, you haven't called me, then the next week you get a minus 10% deduction. And if it's after 1 week late, you get a 0, you may not turn it in. This includes the project that's going to be coming up in June, and I can't accept all work from the whole semester at the end. You must do it as it is due. Again, if you can't get it to me on time, let me know what's going on. I can work with you. I do know that one of the things that Fortis does that shows attendance in the course is not that you showed up on Zoom, okay? That we know we do, but you must sign your attendance attestation. The other thing is the things you do within Canvas, where you submit NCLEX questions or case studies or discussions, Kaplan, quizzes, etc. That shows that you are participating. Now, you need 2 points of reference every week, okay? If it goes 14 days that you have not submitted something or 2 a week, they can drop you without notification. This is why you're going to see me tomorrow. If you don't sign the attestation, please sign it, okay? So make sure you sign your attestations and make sure that you have put something in, 2 points minimum every week. Remember, if you didn't document it, you didn't sign it, that you were here, you didn't, it's not counted, okay? And you can be dropped. So how do you succeed? I mean, I can't emphasize this enough. Make sure that you have some sort of schedule written. With 3 courses going on, you have a lot of things that are going to end up being due, especially at the end of the course. Weeks 8 through 11 are rough. So if you are behind, it is going to be hard to catch up. And I don't want that to happen to you. One thing I do for you is there are 2 things that I leave without open or closed dates, and that's NCLEX questions and Kaplan. Now, I'll go into Kaplan and how I do that, but it's something that you can work ahead, okay? But be careful with working ahead that you don't submit them early and then don't have points of submission on your Canvas. So submit them when it's due. Again, make sure that you're in contact with me, that when you're doing your quizzes and whatnot, if you can have a place that's quiet, that you're not disturbed. I mean, I have heard things like my nephew came over, I was doing a quiz, he started pushing buttons, he finished the quiz and I got a 30 and can I redo it? I can't, okay? That's not an excuse that I could accept, all right? So be very careful, protect your work, okay? Make sure that you submit things on time. I do send reminders all on Sunday evening, say, hey, you didn't do this, oh, you didn't do that, to try to help you get it done, okay? So I work with you because I want you to succeed. I don't want you to fail. That's not what I want at all. I want you to succeed and I want you to enjoy pediatrics because it's actually a fun subject. We know that the first thing you needed to do was go online, go into Canvas, and you needed to do your course welcome. If you do not do those 2 quizzes, you cannot get into any other module in Canvas, okay? So do those 2 quizzes, then you can get into your discussion question. I had a couple students who couldn't get in, and it's because they hadn't gone through and done the course welcome, because everything else is locked until that is done properly. Make sure you have your syllabus and make sure you follow it by when they are due, okay? Again, my sessions are mandatory. I'm going to go over so many things and concepts. Now, how you can do pediatrics and understand it better. And many students have said I was absolutely right. Number 1, do your interactive PowerPoint. You come to class. I'm going to do a PowerPoint and explain things where you can ask questions too, okay? And then the third thing is I do a Kahoots, which instantly is going to test you on the information I just gave you. This week's Kahoot is actually an introduction to next week and what things are important as you're doing the interactive PowerPoint, as you're doing your readings that you need to really look at, okay? So I do review sessions before or after class. If you need help, I'm always available. I'm available for one-to-one, or if you have two of your friends, you know, that are in the school too that need to come to a review, I am more than willing and open to help you whenever you need. You just need to ask and I'll work into your schedule, okay? There are things I have to do, of course. I have, you know, these things like, you know, meetings that I have to show up to, but the first person who's the most important is you as a student. So I will make sure that if you're not understanding something, I'll help you. I've had students who've come in who did very poorly on a first exam and were really frightened and to fail because there's only 3 exams and a HESI. They've come to me before class and we've done just a review of things from the week before. And these students got 90s and 95s on their HESIs because they took the time, the half an hour of time to come to me to tutor. Now, tutor isn't a bad word. It's not like you're doing bad. You got to come because you're not doing good. No, it's a student who wants to do better than they are doing. Somebody who doesn't understand who wants to understand it better. And you know, this thing that 20 points and higher, I've seen it, it's true, it's real, and I can help you get there, but you have to ask. Now to pass this course, you need a 78 in your unit exams, quiz, and specialty exam, your HESI. Once you get a 78, I add in the homework. Please get your homework done. I've had students fail my course because their homework was not done, okay? And homework is in your ballpark. You have control of that. Make sure you get it done. Even if it's late with a 10% deduction, it is better than a 0. Now, to show you the effect of homework grades, I do have the homework grades off for the first couple weeks, and then week 6, I turn them on. And that shows you how homework grades will affect your KGA, which is your overall grade, which is your quizzes, your exams, okay? It'll show you how that affects it. As of week 8, I turn it back off. You do your 3rd exam, you do your HESI, and then once all the HESIs are in and I'm ready for final grades, I turn it back on and then you'll get your final grade. And I'll send messages regarding that as it goes. We know a 78.0 is what you have to have in this course, any of these courses at Fortis. Quizzes are due on Sunday night, 11:59 Pacific time. Make sure once you start, you can't pause. You must complete it. It is 15 minutes long. You only go forward. You cannot go backwards, okay? So 15 minutes is all you have. And I highly suggest do not do a quiz until you come to class, okay? Because once you come to class, I'm going to go over the information because each quiz is on that week's material and you have till Sunday night at 11:59. Any problems during the quiz, sign off immediately, send me an email and I can work with you. If you cannot get a quiz done, you can't tell me on Monday after it was due Sunday. I can do nothing for you. Tell me before anything is due and I can help you. Exams are all done in ExamSoft, and then you'll be coming in on Zoom and I'll be watching you. You're going to need your ID, and there are students with accommodations. Please, if you have an accommodation for a longer time, could you please message me in Canvas so that I know, so that I can make sure that you do get that, okay? And if you need to get accommodations, don't have them yet, make sure that you can't do it the day before the exam. It has to be done a couple days before. Show your ID. We're going to see around your desk. And the one thing that I do that many professors don't is I'll give you a preliminary grade. Okay. Some of you just are having a moment and you're so stressed and so nervous and you want to know what sort of your grade is. I can tell you immediately. Okay. And if it's a good grade, fine. You want to review the exam, make a right there. Send a message to me, please. Can we review the exam? You know, if you've got it, even an 88, I've got 94s wanted to see it. And of course, then I've seen 60s that also want to see their exam. I will go over those concepts that you miss. I don't want you to go through the course not knowing the correct exams and what the questions were. If you miss the exam and do not contact me, you will have minus 10%. If you're missing the exam because something's going on, you're in the hospital, you know, you had an emergency, something goes on, notify me before the exam, okay? And then I can give you your grade without a deduction, but you need to complete it within 7 days before the next class. So it's a Thursday class, you need to complete it by Wednesday night, so that we can give you your grade, okay? If you do not do it within 7 days, you get a 0. So we need to work together very closely with that. Again, always tell me before. I will work with you. Your homework assignments, again, be careful, write them down, know what's due, X them off or highlight, whatever you do to make sure they're in. And again, I will tell you what's due every week at the beginning of class. I mean, I like those big, you know, calendars you put on your desk, and I write everything down so I remember. But you might be the spreadsheet person. It does not matter. Again, you'll get your grade, full grade, if it's turned in on time. If it's 1 week late, it'll be minus 10%. After 1 week, I cannot accept it unless there's an extenuating circumstance that I've known before it was due. NCLEX questions, as I said, they're open. You can do them whenever you want. Make sure you follow the instructions in the modules. It'll tell you what is due. The first week is under growth and development. It is not under pediatrics, okay? Growth and development is where it's at. Make sure you turn them in correctly. And if you don't, I will let you know and send you instructions so that you know how to turn them in. If you still don't get it right, just Zoom me quickly and I can show you very quickly how to get them in correctly. Now, NCLEX questions are worth 5%, 5% of your grade. Make sure you get at least what you want to get in this course. If you want to get an A, do 90s. If you think it's just a B, at least send me an 80, 85. You can do them as many times as you want. There are 50 questions. Do them as many times as you want, and then submit them in. There is no remediation on NCLEX questions, only the questions. Case studies, you will notice on the calendar, they are open for 1 week after that they are due, okay? If you submit them according to the calendar and not the syllabus, you will get 10% off. You must do case studies through the modules. You cannot go to the Evolve site. If you do that to look at questions before you take it, it's going to give you a 0. And I've seen it happen repeatedly. Case studies, again, there's 5 of them. They're worth 5%. You don't want to do that to your subjective grades, because if you're borderline on your regular grade, it could pull you down and it could make you fail. I don't want that for you. So I will tell you the weeks when they're due. Make sure you submit them on time. Make sure you follow your syllabus, okay? In the case studies, the grades, when you go through the modules, will come through on your grade book and will show a grade. If for some reason you see a 0 there, sometimes there's a synapse issue with the case studies evolve and with Canvas, let me know immediately. And I can submit a help desk ticket, or I can tell you to send one, or we both can do one in order to get the grade that you earned entered into your grade book. Now, you have a pediatric assessment project, which is due on June 5th. This is a subject that you are going to pick. It could be a child you saw when you did your clinicals, or it could be your sister, could be your cousin, could be yourself. A diagnosis that is specific to children. It's going to be 3 parts: a 250-word APA paper discussing what is that diagnosis. The second thing is a form, which is the assessment. Do not write within normal limits. You must discuss if it's that cardiovascular. Tell me about the pulse. Is it regular, irregular? Is it what is the heart beating at? Are there murmurs? How are the pulses, the extremities, the blood pressures? Let me know those things. That's what I want to see in the assessment. And the third part is a teaching, where you're going to teach parents or children how to prevent getting, like asthma, from getting an asthma attack. What do you do? Or if you have one, what to do. So the teaching is usually a 5-6 PowerPoint slides. Again, make sure your references are there, and it just discusses some sort of teaching. You must make me aware of what diagnosis you pick. Now, in the modules, there is some examples, okay? I don't want 100 of these assessments on asthma, because that's usually a very common one. So not everybody can't do asthma or urinary tract infection. Pick something that's interesting to you, something you want to know about, something that you knew somebody who had or something. Make it interesting for yourself. So when we're working with the quizzes, again, it is 15 minutes long. It is a question by question, and you cannot stop it. If something happens, stop it and immediately send me a message, okay? Kaplan is at the end of this course, okay? It's week 10 and 11. Now, week 11 has pediatrics A, B, and C. And also the week before, it is math, pediatric math. Now, you do not have to submit me anything. I must go into every single campus, every single student, and look up your Kaplan grades, because I have to look to see if you've done remediation. The biggest part about Kaplan is you go and you earn a grade. Let's say you get 100. You still have to remediate every single question, 1 to 2 minutes per question, okay? If you did the Kaplan and you got 100 and you didn't remediate, you're going to get a 50. Now, the one thing I do is I'm going to go in there once, which means I'm not going to look at your math until I look at the other Kaplans. This will be at the end of week 11. Now, if I see that you didn't remediate or something doesn't look right, or I think you get more points, I'll message you. I'll say, hey, you didn't do the remediation. Would you like to do it to get a better grade? Have it in by this date, and I'll give you that opportunity. Okay, I don't just say, oh, you didn't do remediation, all right, you just get a 50. I'll give you that opportunity to get that done. Okay. So do not submit anything for Kaplan. I go and I look myself. We know the HESIs is a one-time chance. It's either on the campus or Proctor U. I don't know what your campus is going to do this semester. Make sure you get the best grades you can. There is a review. I do a Kaplan, I do a Cahoots review for HESI. And I go back and look at previous HESIs. I see what concepts were covered, and I make questions that cover those concepts. Also, the other two professors has a PowerPoint, which goes over the concepts in a different way. And again, you'll get all of these reviews. I send all of them to you in the announcements. So you have all of the tools you need to do really well. Last semester, the HESI grades improved a lot because I've redone the HESI, the Kahoots for the whole semester, and I redid the Kahoots for the HESI. So it is a really good HESI that really covers concept. And again, I'll redo it again for this semester, ensuring that I have covered the concepts that you might see on the HESI, okay? I work hard to get you the information that you need to understand. So as I said, those Kahoots will be very important for you. There is remediation due. If you don't do it by the time I set, it's usually Monday night, week 12. And then on Tuesday, I start putting all the scores in it. And by Wednesday, you will get the subjective, objective grades, and you'll know what your final grade is in pediatrics. So make sure that you study good, come to class prepared, review the information as I tell you, and you're going to do well, okay? And if you're not understanding anything, please let me know. And the biggest thing I can tell you is communicate, communicate, communicate. Because if I don't know what's going on with you, I can't help you, okay? Any questions? You're good? All right, let's go to this week's PowerPoint, okay? So pediatric nursing is this week is chapters 26 through 30 in the same book that you use for OB maternity. And this is just a continuation from the newborn baby. Now the newborn baby grows. Now, I know many of you probably will go on for your BSN, MSNs, want to be practitioners, which is wonderful. Now, I didn't know what healthy people was until I went for my BSN program. I was like, what is that? Well, what it is there's things that come from the government that says, these are things we can do to make ourselves healthier. And it looks at different groups of people, whether they're children, whether you're pregnant, whether you're elderly. What are things we want to really look at to teach that we can make our population healthier? Well, in children, we look at growth and development. We look at nutrition, which is the most important concept of pediatrics. Children need to eat properly. Without proper nutrition, they don't grow well, and their cognition levels is going to be decreased. And oral health is another thing that it's been focusing on. And you'll see as healthy people 2030 comes, be different things that are there. This is where many of your papers in your BSN program come from. So become accustomed with healthy people. Some of the problems that we see in childhood is obesity, type 2 diabetes, and even younger children. And this is because we have children who come from parents that have to work with fast food, comes with children who now are into their iPads and their phones, and they're not out running around like they used to be when I was a young kid, because we didn't have that. And we didn't have cartoons 24 hours a day. So we'd be up out in the backyard doing whatever, in the playground, whatever. Childhood injuries is the biggest thing that children get. And the biggest injury that children get is motor vehicle, whether they're infants up to adolescents, because it's improper car seats put in, and adolescents get driver's licenses. And they become, yeah, I can do anything, and they'll have those injuries. Violence, bullying, you're talking about school-age children, and children do have mental health problems. They have schizophrenia. They, hear voices. They are bipolar, and it is true and real, and I've seen it live in action. These are different pictures which will show you things can happen. They touch guns, suffocate with plastic bags. I live in South Florida. I'm in Homestead, Florida, right before the Florida Keys. And I have a pool in my backyard. And I have a grandson who's 5. Well, at age 2, this kid could swim, could go underwater, knew where the sides were, know how to float on his back, all because there's a pool. And the child will not, to this day, and he's 5, will not go in the pool unless he asks permission first because of that fear of drowning. We know pots on the stove. I had a brother who burnt his arm and had scars for life there. And of course, getting into medicine is what kids do. They like their vitamins and they like their Motrin and Tylenol tablets. They tend to go to them and eat them like candy. The highest risk children are your children born early, your premature, your very low birth weight, or your low birth weight children. They're born and their skin isn't completely intact. You know, they're born, their eyes are still fused, some of them, and they're up for sepsis, lung problems, their lungs are not made correctly. I mean, their whole body systems are very immature. And it causes problems in the future. Children in daycare, that's another one. You think about children in daycare, what do kids do? Everything in the mouth. They swap their spit, is what I call, from one toy to another toy in one mouth to another kid. And it's just normal. It's just what they do. So that, again, causes health problems. More and more people are in poverty and homeless, and they can't eat properly. They don't have, a proper place to live, and that causes problems. Immigrant families. Now, I live in an area where there are a lot of farms and a lot of, tomato farms and, all of the fruits and vegetables down here, and they have immigrants that come in to pick them. These children, working in an emergency room is what I noticed. These children were some of the sickest kids who came into the emergency room because they were afraid to go and receive care because they were afraid they were going to be sent back to where they come from. So, and we don't do anything like that in nursing. What we do is take care of the child, period. Children can have chronic and psychiatric illnesses and disability. And sometimes they can't get to the doctor. They don't have the $5, $10 copays. They don't have a car to go. All of these things you don't think about, but it's real. The kids, usually from the immigrant families, either had to find somebody who had a car or they took 4 buses to get to the emergency room to take care of their kid. And it's a reality. Infant mortality in the United States is extremely high as compared to many other countries. We are behind. We don't do everything we should do. Now, I've worked newborn ICU since the 80s. I've seen so many differences in the way that we care for them, but there's so much more that we need to do. The biggest thing that we know that if we have a child who has a low birth weight, there's going to be more issues with that child. I mean, usually low birth weight and premature, their lungs are not formed, their brains have fragile vessels, they bleed into their brains, it causes, cerebral palsy and, decrease in cognition levels. So, this is big in the little children. Once they get over the age of 1, it's less death rates because now we have found those underlying medical conditions that the child is born. We don't know if they have things like cystic fibrosis or hypothyroidism. We don't know. So now by the age 1, we have determined it, and they're usually placed on a good treatment. In the school age, it's the lowest death rate. But once we get to adolescence, that death rate rises again. Adolescents think they know everything and they're smart and anybody can tell them nothing. Okay. And they tend to do things that they shouldn't. They play with guns. And the other thing is suicide. Adolescents, their big thing is body image, okay? And they don't feel like they are what they should be. And many of them suffer from depression and commit suicide. So family, social, cultural, and religious influences on children. Now, family is what we take care for in pediatrics. It's not just a child. And many nurses don't go into pediatrics, so they don't want to deal with the mother or the father because sometimes they can be overwhelming. Because the thing about me is they gave me all the time the most difficult parents to work with because I knew how to deal with them. And all they want is information. They want to be a part of the care. They want you to just acknowledge that they are scared and to educate them, and they can be your biggest helper. But it takes somebody to be able to speak to them um, and get them to understand what our job as a nurse is. You know, a lot of times they're angry at themselves. They think that they caused the child to have a heart problem or this problem or that problem, you know, and many times it's not. It's just genetics. It's just something that just happens. But a family is whatever the family says it is. It could be a grandma. It could be a grandma, grandfather. It could be a mother and it could be a mother and a grandma. It could be two women, two men. It could be a single parent, a father or a mother. There are so many different things that a family could be. But remember, a family isn't a mother and a father and a child. It's like the normal, what you would think. It's not that way for everybody. Now, in pediatrics, we want to give the best care we possibly can, and we want to do it with the least care, pain as we possibly can. So our job is to do things to make it better for a child. Now, when I was at Nicholas Children's Hospital, which is a big facility known in Southeast, one of the biggest hospitals, children's, I developed a program called Huggies, H period, U period, G period. It's help us give great injections efficiently and safely. And what that program was simply is a parent would hold their child before they got an injection. And then after the parent could just put them up to their chest and comfort them. And what we saw was less stress and less fear, as evidenced by less crying before and after. And they did so much better. It was one of the research projects I did at my hospital, which is still continuing today. So it is a great program, and that's part of traumatic care. It's do no harm, minimize psychological and physical distress just by hugging their child for an injection. And many things we do, putting numbing creams on, distracting them, et cetera, et cetera. And this is all about the family, and I talked about that. Culture plays a big thing as you're dealing with children. Now, you don't have to understand all the cultures. I don't, and I've been around a long time, but I've learned if I don't understand, I ask. If I don't understand what that means, I'm going to say, so what do I need to do to help your child? How should I do that? Which is part of the way that you believe. And these parents or this child is going to have more respect for you because you asked the question. It's better that than you do things to offend culture. There are some cultures that don't want a male taking care of a female patient. There are some cultures that don't like to be uncovered, and you should only uncover what you're working with. Okay. So respecting that. Or are they the person who has to do prayers all the time? Or whatever it is, you ask and they'll tell you, and then you could respect that. And that's going to make the hospital visit better for you and for that family. Now, there are some health beliefs about what causes illnesses. I think that I was very close with a Dominican family, and I can't tell you how many times they said to me, oh, no, it's raining. They can't go outside. They're going to get sick. And now, yeah, because they got wet. And I'm like, okay, so you dry off and change your clothes. But there are people, that's part of it. Another thing is, I know that the Hispanic grandmother, especially Cuban, and my children are half Cuban, the grandmother doesn't want children walking around on the floor without socks. They think they're going to get sick with the cold of the floor. So I've had many of these children come in with a fever, and they're in 2 layers of clothing, a hat. Now, this is in Florida, South Florida, a hat wrapped in blankets because they have a fever. And I'm like, so how do you expect the fever to go away if you have it all covered up? So I have to describe, well, if you have a fever and you hold it inside, it's just going to get higher. So you open up everything and the fever can go away. And if you take their socks off and let them walk on the floor, it's cooler, and that's going to help that fever stay down. And when you explain it in a simplistic way like that, they get it. I said, doesn't that make sense? They can get the fever and go away. They go, oh, okay. Also, I've been involved with one patient I remember was really sick in the ICU, intubated, and they wanted to do some sort of voodoo, something, I don't know what it was. And they wanted to do this thing with this child. And they described what it was, because I need to know they can't do anything that can harm the child. So, but they can do whatever, you know, as long as it doesn't harm the child. Well, I was quite pregnant at the time. They made me tape a quarter to my belly button. And I'm like, okay, whatever. I'm not going to argue. They didn't want the evil spirits to get into me through my belly button, into my baby. I'm like, okay. They did whatever they had to do. They were so happy. I pulled all the curtains. They did what they did. Believe it or not, a day later, this kid was doing a lot better. Okay, I don't know if it was that. I don't know. I don't know. But it's not for me to decide if this is right or wrong. I don't have to believe in it. I have to respect the parents and their culture and their beliefs. And this is how I did it. I said, here's your quarterback. They said, nah, you can keep the quarter. But it was something that happened, a real true. So there's other things to do with religion. And the one thing with religion is I've had, working in the cardiac ICU, many children born, half a heart, really sick, you know, going to big surgeries, and they want their child baptized. Well, most hospitals have a list of on-call, you know, religious people. So I would make sure that they got that person in there if they couldn't get their own. Another big deal in children is when you have a child with low blood counts that is very symptomatic, which means they're having periods of bradycardia and apnea, and they're symptomatic with low blood counts. A Jehovah Witness will not sign a permit to give blood. It's against their religious beliefs. So we call risk manager and we get a court order. Now, I can come in with the blood and swing it around in front of those parents. And what am I doing? I'm disrespecting them. So many years I worked the night shift, and I would let the parents go home if the child's condition, you know, allowed me to. Let them go home, and then I would give the blood. They never had to look at it. They didn't have to see it. Call me at this time. I'll be done. I'll tell you how they did. And they respected that. They felt that I respected their beliefs, and they didn't have to be a part of it. I've also done it on the day shift where the mother was there, and she, go outside, let me take care of this. I'll tell you when to come back in. So she did, but I covered up all of the blood tubing because it was in a syringe pump, which means, because it's smaller amounts and smaller children, covered up the tubing. They never had to see a part of it. The blood bag, I didn't leave it out dangling in front of her. And when it was done, I just flushed it, got rid of all the stuff, got rid of it. Now, the crazy thing about this child that I'm talking about, the last day I worked in the hospital, this family came in, the son and the mother. I saw the name and I went back, looked at the history. I'm like, yeah, this is him. I went in to say hello. I said, you know, I was always known as Betty Boop because you don't forget that name, you know, and it gives them a reference of, who's your nurse? Oh, that's Betty Boop. And, you know, it helped them because there's Nancy and Helen and, you know, Marcia, and there's just so many names. I walked in and I said, do you remember me? And she goes, oh my God, yes. And she said, I've been looking for you for a long time. Gave me a big hug. Oh, it's so nice to see you. I said, oh my God, he's such a beautiful big boy now. And she goes, oh, thank you for everything you've done for my boy. She remembered how I respected her and her rights. I didn't say, what are you crazy, not giving your child blood? No, that's not for me to say. I had to respect her beliefs. Nurses are a psychologist. We are their therapist. You know, parents feel that they've done something wrong to make their kids sick, especially those young children just born, whether it's newborn ICU or cardiac ICU, and telling these parents that you did nothing wrong. In fact, wow, you got your kid here, great. You know, we're going to take care of it. You know, you need to get some rest too. You know, being understanding is part of nursing, especially pediatrics. You know, parents feel that, you know, it must have been that Tylenol I took, you know, at 8 weeks before I knew I was pregnant or something that caused whatever. And I'm like, no. I always tell the cardiac parents when I first see the mother, you did nothing wrong. It wasn't that Tylenol or that glass of wine. It was nothing. You know, this is just something that happens during development in the fetus. So don't sit here and say you did something wrong. And just saying those things do help. Now, nurses, especially pediatric nursing, you know, you need to teach them. What I have found, parents usually are my best eyes and ears. They can watch their children. You tell them what to watch for. Something's going on, they can come get you because you can't be in that room all the time. So they can be your best ally. They're the one that they have to do these things at home once they get there. So why not teach them to do them now? Once you know, showed them, they do it back to you. They can do things for you. So I have always been a firm believer in teaching my parents how to take care of their children or a child to take care of themselves. So we are that support. We also coordinate between the physician and things parents need for their children, getting the social worker involved, getting that referral for something that they need. Nursing does more than just taking care of children, making sure that as they leave us, they're also going to be okay. Genetics and nursing, you know, and children. You know, you think genetics, you think Down's children. I mean, I think that's the first one that you think of. So assessing a child, we're going to use ADPI, just like we do with an adult. We're going to look at the child, assess it, assess all of the systems, make up our diagnosis, and we're going to plan and implement. And our biggest thing is that, did it work? Did it work? I mean, as simple as assess the child, my diagnosis, kid has a fever. I gave some Tylenol and now an hour later, the temperature's down. Did it work? Yes, temperature's down. Now, African-American boys age 15 to 19, the leading cause of death, well, it's like one of these either or. It could be suicide or it could be firearms because they tend to get into things they shouldn't in gangs, etc. I mean, like many other groups. So growth and development, really important. Children are born, they can't even lift their head. And then they can lift their head and roll over and, you know, get on their knees and creep. And then they stand up and walk around holding on things and then they can walk. It is all interrelated, simultaneous, and ongoing. Now, it doesn't mean a child doesn't skip steps in between. There are children that maybe go from walking, you know, creeping on their knees, and they go right up to creeping around the couch and walking immediately. All children are different. No child is the same. As long as they're going forward in the progress of what they should be doing, they're doing good. We call these things different things about how they grow: directional, sequential, developmental. And this is all just about there's certain things you need to do first before you move forward. Cephalocaudal, cephalic is a head, right? Caudal's tailbone. So it is, what do infants do first? Well, they're born with no head control at all. And about 2 months, their head, they were able to hold up, peek around, look around. And then they start with their shoulders and trunks. And we know they sit before they walk. This is all part of this directional trend. Sequential means first they have to creep, and then they creep, and then they walk. You know, first they roll over, then they get on their knees, and then they creep, and then they walk. It goes in a certain pattern. It goes from here to here to here, and that's just part of it. And developmental pace, it's at certain times. These things are expected. When infants are born, they're born with a heart rate of 140 to 160. And as they get older, the metabolism slows down and their heart rate goes down to the point where they get to be, adolescents or adults at that point. Their heart rate's 60 to 100, normal, right? Part of what an infant is. Now I'm going to send you a vital sign sheet when I send you these recordings. You're going to get those from me. When infants are born, they do not regulate their temperature at all. If you leave them uncovered and not under a warmer, they're going to get cold really quick. So understanding that as we're assessing an infant, we will uncover things as we need it or have them in a warmer so that they keep their heat. It's very important. We know infants sleep a lot, and as they get older, they sleep less and less and less. And nutrition, the single most important influence on growth. If a child is not getting proper nutrition, they're not going to grow and their cognition isn't going to be where you want it to be. Okay. So that's why if we have an infant born at 7 pounds and at 6 months, it should double the weight. And if it was 7 pounds at birth and at 6 months, they're 10 pounds, they're not getting nutrition. They're not where they should be. And probably you're going to see that in growth and development. They're not doing the things they should be doing. So we can, because of understanding growth and development, institute some sort of intervention, whether it's this child with not enough nutrition, maybe given something with more calories, maybe in the formula, supplementing breast with formula, something to get them caught up on their weight, okay? And we know temperament is coming from the family. You have a calm family that always meets the child's needs. The child's going to be calm and relaxed. Now, I'm also going to send you a handout on human behavior. Freud is oral, anal, sexual. That's all what he talks about. Erikson, Piaget, and Colbert are the 3 you're going to see on exams, quizzes, and everything. Okay. Warning, 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 okay? Erikson, for instance, Erikson talks about an infant and it talks about trust versus mistrust. And what does that mean? Well, an infant cries, a parent goes, picks them up, changes the diaper, feeds them, whatever. That's trust. Well, what if that mother doesn't go pick them up and that kid always is crying and nobody gets them? That's mistrust, okay? So that's part of what you're going to see. Piaget talks about understanding, putting 2 and 2 together, like if they have a rattle and they know it's put underneath a blanket and mommy walks out of the room and the child wants to rattle, he knows object permanence, that it's underneath the blanket. He goes searching for it. So that's more about cognition, Piaget. And Colbert talks about right and wrong. And there's a consequence for right, good things, and a consequence for bad, some sort of punishment. One of the things that is the biggest thing with growth and development and increase in cognition on children and infants is toys. Toys are so important. The sensorimotor development is that touch. What does it feel like? The soft, the plastic, the hard, interesting. And then where does toys go with infants? Right in the mouth, right? And the mouth, oral, they bite, they suck, they chew. This is actually gratification. This actually is a self-soothing device, things in mouth. For instance, that pacifier, you give an infant who's crying and doesn't know what they want a pacifier and gives it to them or something to suck on, they are self-soothing. They have done many different back and forths about pacifier, good, bad, good, bad. In the 40 some odd years I've been doing nursing, I've seen they're good, no, they shouldn't have them, or they should have them. Well, today we believe they should have them. There was actually a research article done by Harvard neurophysicists about sugar water on a pacifier on an infant getting a circumcision. They said putting sugar water on a pacifier that they're sucking during the circumcision was just like an infant who got morphine before. It worked that well. Okay. So self-soothing, it's that distraction, and they suck, and it does self-soothe. Crazy, but it works. It does work. We know toys stimulate everything. They'll start with looking at it, even infants, even the pacifier, they'll put it in their mouth and look, and then they'll have it all over up in the air. It's just part of that sensoromotor. So the touch, the mouth, and then playing it. And maybe it's an airplane flying there. I don't know what they think it is, but it can go up here too. Now there's all sorts of play, and you need to pay attention to play because you'll see questions regarding them. And these are the types of plays that you're going to see. So either they play alone in the corner. This is very common with your autistic children. They don't play with people. They'll play in the corner by themselves. And even when you call them, they don't want to be interested. They just want to play. Then you're going to see a child looking at somebody else doing something. Or then you're going to see the same toys playing next to each other, but not together. And then you'll have some children, a little bit older now, who start to play together with doing something, but with no goal in the end. And then cooperative play. It will be two children playing together, say, let's build a house with these blocks together. So there's a goal when they finish. So play is important. You will see it again. It is such a great opportunity play that children play alone and with parents. It's a great moment. I know with my grandson, he lived with me for the first 3 years. And as a grandparent, you see more things than you do when you're a parent. Because as a parent, you're so busy trying to get everything, make the house clean and have dinner done, and you're working and groceries and bills and all of these things that you don't see everything. But as a grandparent, you see so much more. And it was such a pleasure to have him for the first 3 years. Seeing these maracas, we had musical instruments. We had a tambourine, we had a stick you bang, we had a bell, we had maracas that you would do. And we made up a song and we would sing, I love Christian and Christian loves me. And we would shake and go boop, boop, beep, doop, and this child would smile and I would smile. Now I didn't do it for a year and came back and I saw the maracas and I started singing and he stopped and he started clapping. It's like such a thing, play, parents, it sparks imagination, and it gets the child involved. Parents is a great thing. We know toys, they push, they pull, they fly in the air, and they sail across the room sometimes. But this is all part of these children moving their muscles and getting stronger, making their muscles stronger. So it's a great thing, play. Assessments. Now, as nurses, you're going to get patients and you need to do an assessment, whether they're in an ER or the doctor's office or being admitted to a hospital. So first thing you have to do is get on their developmental level. Now, like this little girl here, I would say, oh my goodness, you've got a beautiful smile. I'd sit down. Firstly, I'm not going to touch them. I'm not going to try to assess, do nothing. I'm going to build a rapport. I want to make them know that I'm not going to hurt them, that I'm going to be some fun, Then I'm going to say, I'm going to listen to you. So here, you want to listen to me first? Here's the stethoscope. Or you want to hear your heartbeat? Wow, listen to that. And you make it fun. And when you make it fun, these young children, which if you don't, they're going to run in the opposite direction. And they're going to be, get away from me. You're going to hurt me. Because many times they think of a nurse as all they're going to do is give you a shot Because what do we do the first couple of years to children when they go to the doctor's office? Immunizations, shot, 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 shot. So that's all they think about. So as a nurse, you don't want to make yourself extra work. So if you make it fun, guess what? You will have fun. So I used to go to work and play exactly every day. Even in an ICU, I would play every single day. So you need to get on their level and then make it fun, and you can get an assessment done. Children are born with congenital abnormalities. I mean, it could be a cardiac condition. That's, one of them, but many more. Club feet. You could see children born without fingers, arms, legs. I had one friend whose daughter was born without a fibula in her leg, and you can't replace it. So she had to have a amputation below the knee. But as a newborn, she never knew she had two legs. So for her to have a prosthesis was great. In fact, when she was 4 years old, when she met my children, she was running up and down the stairs with her leg, her false leg, beating my children up with it. And they're like, "Mom, she's trying to hit me with her leg." I'm like, okay, she's very comfortable with her quote disability. It wasn't for her. And then, of course, we have all the sort of syndromes, Downs, Prader-Willi, Turner, and I could go on and on with the amount of syndromes that we could have. But when we know what a syndrome is, we know what to look for. And then, of course, if there's any sort of drugs that go in, whether alcohol, cocaine, or other ones, they can cause issues. Also, being exposed to rubella, exposed to radiation in high temperatures can also affect the infant. And then metabolic, that's why we do those little circles on that piece of paper before newborns go home, is to test for PKU, because we need to know if there's metabolic so we can put them on special formulas and watch them so that their cognition and they grow properly. And of course, genetics. I see 22, I think of Q22 deletion, which is the George syndrome, and chromosomes play a big effect. And if we have one child that has a syndrome, we need to suggest to these parents to go for genetic testing to make sure if they want another child, that what's a possibility. So the role of the nurse, nurses today do so much more than we did years ago. We are there as that medium between physicians, family, and the child. And we need to give education. We need to support. We need to give those hugs to those parents who feel, I did something wrong. That's why my child has whatever, and sometimes it's just to say, when I worked in an emergency room and get a young child in, and the child's been sick for 5 days and they've gone to the doctor in urgent care, and now they're coming to the ER because they don't know what to do. I said, "Oh my God, you've been such a great parent. You've done everything you should do. Oh, you must be exhausted. How many days has your baby been sick? You have done a great job." And just saying those things, you have just relieved so much stress off that parent. It's because they've been recognized. That's all they want. They've done the best they can do for who they are, and that needs to be recognized. And it's something that I'm telling you, parents hug me when they're done. They say, "Thank you for understanding." Okay. Another thing we need to do is promote attachment to a child. Think about that child with cleft lip, cleft palate, and that whole lip is open, and it doesn't look really nice. There are parents like, oh, they're afraid to touch their child. Do you know what I do? Sit down in that chair, I wrap the child up in a blanket and hand it to them, and I'll say, "Oh my God, look at that head of hair they have. Oh, such big eyes. Oh, and those cheeks, I want to pinch them." And forget about this thing that's open that looks really horrible. I said, "Oh, don't worry, we'll fix that. Your kid is beautiful." And what does that do? That promotes that attachment that may not have taken place, because they are afraid of what that child looked like. And of course, as nurses, we can foresee maybe they're having trouble with, swallowing and eating. Maybe they need speech therapy to help them with feeding. So we can say, "Hey, doc, let's order speech therapy on this child," and think they would benefit. That's our job. We are in the middle. We are there to make sure our kids get the best they can. Now, I talked about Piaget. I talked about the cognition, and this question is about cognition. So that object permanence, I just told you, that's about that rattle underneath the blanket, and the kid just goes and looks for it for himself. He knows that even though it is not in visible sight, that it's still there. Okay, that's object permanence. Now, pre-operational, concrete operational is how things work, or there are children who like to collect, whether it's dolls, whether it's baseball cards, whatever it is, and they like that sort of structure. So these are things that you're going to see, and here they are, and it's a beautiful slide. In fact, I would take this slide if I were you. I would print it. I think it really shows the ages and these different developmental phenomenon that you're going to see, questions related to it. So it is a great thing. Object permanence and stranger anxiety. I mean, a lot of young children, infants, they don't want to go to anybody else except mom and dad. And if you try to give them to somebody, what do? They turn around and try to reach for mommy and daddy. Communication history, physical, remember HIPAA, and remember pediatrics has children that are 18 years old. And if they are alert oriented, they have to be the one that lets their parents listen to the reports and get information. And as a nurse, you need to ask, may I speak openly in front of your parent? Just like you would do if there was somebody in the room that wasn't, family or somebody else, an adult, you need to ask permission. That's a HIPAA. Communicating with parents can be difficult. Some parents, especially when you have a group of people in a room. I mean, today with COVID, you're not going to see that, but I've had 10 people in a room and they all want to tell me about the kid all at once. I'm like, whoa, wait a second. Who's going to talk to me? Just one person, please. I can't listen to everybody. And then making sure they're only telling me about this incident. Why are you here today? Your child's 9 years old. Don't tell me about the first year of in and out of the hospital with ICU. Okay, mention, yes, they had premature at birth and they had these issues and we fixed them, but catch me up to now. What's going on today? Be aware of culture. There are some sort of cultures that the mother can't talk, the father has to talk. You can't look in their eyes, you can't touch them. Be aware of cultural things. And if you don't know, ask them. They will tell you because they want things their way. And use that silence, of course. And then, of course, be empathetic. I think probably one of the most important things, like, wow, you've done a great job. You must be exhausted. That's all they want to hear. And then, of course, if your child, parent speaks another language that you don't understand, you can't take information from another family member that speaks both the languages because they can interpret it with their feelings into it. So you must get an interpreter. Communication in children is all different. You remember, get on their level and make it fun, make it play, and they can really tell you a lot of different things once you got their confidence, okay? Wow, you're wearing a Batman shirt. I love Batman. But wait, don't you like Spider-Man? And you start talking different things. Or where'd you get those freckles from? Something, get them, relaxed. So when you're in a room and you have more than one person, find out who's going to talk to you, what is a chief complaint, and what are the symptoms? Tell me about it. As when you're admitting children, you need to know things like birth history, dietary. Do they not eat certain things? Are they allergic to certain things? Was there any other operations? Allergies are important. If they've had any medications, immunizations is quite important because then you know where to place a child on the floor, if they should be in a room with another child or not. And then, of course, looking at that growth and development. Are they where they should be for that age? And habits. If you have a parent who can't stay with the child due to many, many different reasons, and they have something that they need that comforts them, whether it is, a little stuffed animal or their blanket or their pacifier. You need to know so that if they have to leave or just go to the cafeteria or to the bathroom and the kid's screaming, you can walk in and say, "Oh, they dropped their blanket on the floor. Let me give it to the child." And it calms them down. So you need to know habits. With adolescents, you can have parents leave the room. In fact, I encourage leave the room, talk to the adolescent, and you could ask questions about their sexual history and things that are pertinent to why they are there. You do not have to tell the parents what they said unless the behaviors they're talking about could be harmful for them. Okay, that's in confidence. You need to know if it's mom or dad who's the boss of the family and who you're speaking to. How are they doing in school? Is there any, of course, the habits again, and then parent-child relationships. Let me tell you, you can see that really easily. Now, I worked in the last part was in an emergency room. There was rooms with doors. So you put them in a room, close the door. I would walk into some rooms and the parent has the child on the lap and the child is just there being comfortable. I've also walked into rooms where there's a stretcher and there's a bedside table that has gauze and alcohol in it. And then they have the otoscope up on hanging on the wall. It's off the wall. The little black things for the ears are flying all over. Alcohol, gauze all over the floor. The parents there on the phone, not paying attention. I've seen it. So you know that that parent has no control on that child and doesn't even try. So now I have to give medicine to that child. Who's going to end up doing it? Well, probably me. Know what their dietary intake is. What do they eat? What don't they eat? If they're vegetarian, don't put meat on their tray. And that's, you're not respecting their cultural rights by putting meat there. So make sure it's not. And if a child is too big or too small for their age, if they're 1 year old, they're born at 7 pounds and they're 21 pounds, they're eating good. Okay. So whatever they eat, fine. But if they're less than or more, get a nutritional assessment. Growth is done every single visit, whether doctor's office, mission, ER, urgent care, we do height and weight on every single child because we're watching how they're growing, seeing if they're in where they should be with their growth and development. Taking their vital signs, remember all the vital signs are different on children. That's why I'm going to send you the sheet so that you can see it. And there's something we call the general appearance. Is it well appearing or sick appearing? And you can tell when a kid looks sick. They got droopy eyes, they're watery, they're not running around looking normal. And then there's a happy kid running around the place. You're like, okay, well, why are they here? I mean, but you can see them both. It could be urinary tract infection and that's what they're doing. But a sick kid, you can really tell. You can look at their skin, look and see how they're breathing, retractions. And a well child, you should not be able to feel lymph nodes. If they're sick, they have an infection, upper respiratory, something going on, you can feel lymph nodes. Again, look through everything. You've been taught as an OB, when you have a delivery of an infant, you should take a rectal temperature to get an accurate temperature, right? Well, actually, you are doing it to make sure they have an anus. Children are born without an anus, and it is a medical emergency. They have to go and do a colostomy on that child because all of those secretions have to go somewhere. There's no exit, there's nothing. And they'll never have one because there is no anus there. We also will be checking their reflexes, and we do very easily check the reflexes on children. We can check, rub the little cheek, and the kid's face goes towards that rub, and that's called a rooting. It's looking for something to eat. Another thing, clapping your hands, boom, boom, and the infant goes like this and splays. That is the Moro or startle reflex. So there are reflexes that we can check. Again, we're going to check either head, chest, abdominal when we need to. And of course, taking a height on a little infant you think would be very easy. Well, this child here sitting there smiling, you're lucky. Most of these young children, what they'll do is they'll run. They think that little board's going to bop them on their head and hurt them. So what do you have to do? Let's make it a game. I'm going to go and put it on my head. I said, look, it just touched. Oh, this is my number. You want to do it too? Let me see what's going on. So when you do it that way, you get my number, they get a number, you say, oh, look, you got a better number than me. Yay. Now, they'll never be afraid of putting that thing and getting a height again. So it's how you deal with these children. Blood pressures. Blood pressures are done on children, but they're all different sizes blood pressure cuffs. I mean, you know about small, regular, and large blood pressure cuffs for adults. Well, they're size 00, which fits around my little pinky that we do on premature babies, all the way up to that size 00, 1, 2, 3, 4, 5, 6, and then it goes into the adults. Make sure we choose the right ones. And I use D on the low leg. I use that a lot for the 2, 3, and 4-year-olds because I can have them push a button. I can hold their leg. They tolerate it better than up in the arm, like letter A. They just feel that hurts, but on the leg, they tolerate it. And it's the same blood pressure unless you're cardiac. Okay, pain assessment in children. Now, one of the things that is my pet peeve is that children suffer because nurses don't give either enough medicine or don't give it frequently enough to children. They feel that they don't need as much. Well, they need just like any other patient does. We give mics per kilo, milligrams per kilo on children. We give them proper doses. We don't overdo them. So children do suffer. Another thing with children in pain, children are afraid to tell you that they're in pain because they don't want to get a shot. They don't want to be hurt. So we need to say, listen, but your tummy hurts. I'm not going to give you a shot. We'll just put it through that little tube in your hand. So you're not going to feel it. And then they're like, okay, especially that kid 3 to 6, that area, they're really afraid of it. I mean, nurses wait too long. And then, of course, remember, we need to go back and evaluate, did it help? As an adult, there's all pain, chronic, recurrent, persistent, rheumatoid arthritis, sickle cell, is, these chronic pains that come through. It could be a medical procedure, could be tubes put in the ear, could be tonsils, could be appendectomy. All of these things need pain medicine. I think an ear pain is one of the worst pains on children, and nurses forget to give the child something. And it's as simple as giving them some ibuprofen. Ibuprofen works well on ear pains. It's an anti-inflammatory. What is an ear? It's an inflammation of the inner ear. So it helps. Now, we evaluate pain and we have tools to use it. The ones that I've used the most, that I've seen used the most, though I give you all of them, like the book is, but I use FLAC, FACES, and numeric. FLAC is for nonverbal, any child, any age, or up to the age of 3. And it measures what their face looks like, their legs, their activity, their cry, consolability, and they get a number. And it goes to 10, just like numeric. Numeric is ages 8 and older, okay? Faces is wonderful. They can sit there and look at a face and they'll tell you a preschooler, so ages 3 starts the faces, and they'll point to it and they'll say, okay, this means you don't hurt. And this one's really, really terrible pain. Which one feels like you feel? They point to it. They really are good with it. So chronic pain, just like it would with an adult, affects children. It affects their physical, emotional, social functioning, and of course in school they're missing it. So making sure that we do take care of their pain is important. One of the things I've seen with pain is cultural things. I've had Hispanic fathers tell their male sons, oh, you don't have pain. It doesn't hurt. You don't need anything. Suck it up. And I'm like, listen, Daddy, your son has a fractured arm. I'm going to give him something because it does hurt. So I think at this case, he doesn't need to suck it up. He needs something. And you say it nicely, okay? But you'll see cultural. Some of them don't want it because they feel they don't need anything, or they're afraid one shot of morphine is going to make them addicted. And I'm like, one shot's not going to do that. And remember, with pain, it's just not the medicine, it's also other stuff. We can distract them, get them an iPad, turn on the TV, turn on music, give them some crayons and coloring, many things. Also, repositioning them in bed, elevating the head of their bed, giving them hot, cold, all of these things. And infants, what are we going to do? That non-nutritive sucker, pacifier. And that is a self-soother. And in this case, this little kid is doing kangaroo care. I can't tell you how many kids were irritable. And you can see their heart rate's up and they're just flailing and they don't get comfortable. And you put them on mom's bare chest, their heart rates go down, their respiratory rates go down, and they go to sleep. It is awesome, kangaroo care. Tylenol should be used in between the narcotics or NSAIDs. We do not give ibuprofen to children until they're 6 months old. From 0 to 6 months, only Tylenol. And we could give transdermal things. This girl's smiling. What she has on her arm is EMLA, a numbing cream. Looks like she's going to be getting her labs drawn, but she knows it's not going to hurt because we numbed it first. And we can have pain for all different things, you know, and making sure that they're medicated, they're prepared, be honest to these children. And this is all children really want. And then remember, it's not just narcotics. You alternate them with just the Tylenol and then positioning, hot, colds, distraction. These kids do really well. Any questions? Interesting things are children, aren't they? So are you ready to play a Cahoots? Now this Cahoots is something that also is showing you what to look for when you're looking at next week's interactive lecture, okay? I believe there's 33 questions and we'll be done right on time, I believe, tonight. If you need to leave, please, it's okay. I understand. So go to kahoot.it and put in the code that's up here, 6392985. If you have one of those Q readers, put it on that little thing there and you could be up there. Now, I don't look at who gets the most right or wrong. You're not graded by those things. This is a tool to help you understand. It's that third repetition, interactive PowerPoint, the PowerPoint I just gave you. And now it's a Cahoots to reinforce that learning, okay?
Can you tell us the Kahoot code again?
6392985. I'm going to get started. You all can come in and the code is in the bottom corner that you can look at also. From a worldwide perspective, infant mortality in the United States is what? Are we good with infant mortality? Do infants, a lot of them die in the United States?
I can't see it because I'm on my phone.
6392985.
No, I see the code. I just can't see the questions and stuff like that because I'm on my phone.
All right, you
I
need
can't see
a
'em either.
phone. Okay, you need a phone and you put it on the phone and then you have your computer screen.
Yeah.
Shows it to you. So right now you just listen, okay? You can
Okay.
go back, look at the recording and see the questions and all the answers, okay?
Mhm.
So it is the highest, okay? There's other countries that do a lot better than we do. The leading cause of death from unintentional injuries in children is what? Unintentional injuries. And it's motor vehicle, okay? It's not poisoning, it's nothing else. The unintentional injuries, the leading cause actually is motor vehicle. That's why it's important that children are in car seats and secured properly. Which statement is most descriptive of the pediatric family-centered care? Well, family-centered care, as we know that, family is the one thing that they have, that's all their culture, their religious, their beliefs, all is about the family. So it is that only constant in their life. Very good. The major cause of death for children older than 1 year old is? And it's unintentional injuries, which is motor vehicle accidents. Very good. Which statement best describes the process of critical thinking? We use critical thinking every day of our life. I mean, you want to make something to eat, you need to know if you have all the ingredients. If you're in the grocery store and you want to make something, you make sure that you buy all the things. That is critical thinking. And in nursing is finding a patient with a diagnosis and then figuring, what do I need to do to help them? So it is purposeful and goal directed. What is probably the single most important influence on growth at all stages of development? Nutrition, nutrition, nutrition. They won't grow as well. Also cognition, they might even be delayed without proper nutrition. That's why we weigh these children. Frequent developmental assessments are important for which reason? Why do we look at vital signs? Why do we look at weight? Why do we look to see if they're turning over, lifting their head, walking? Why do we do that? Is because we can tell something's wrong and institute early intervention quickly. Children are so resilient. That's why I loved working with children as much as I did. It's because you institute early intervention and these children catch up so quickly. I mean, I think the one that most of you have ever worked with it is speech therapy. Children who don't speak well. I mean, within 6 months, they're chattering up a storm. It's just part of early intervention. Which function of play is a major component of play at all ages? What did I tell you play is all about? So play does everything here, but it's because of the sensor or a motor. It's that touching and feeling of the textures and the mouth, and then moving it around is the creativity, provides that socialization, and that does the intellectual development. So it's a sensoriomotor activity. And that's part of what Piaget says too. The head to tail direction of growth is referred to as head to tail. That means they lift their head and their shoulders. They creep and then they walk. So that's cephalocaudal. Cephalocephalic, head to tail, caudal. What is the single most important factor to consider when communicating with children? I need to go in there and do something for this kid. I need to go take a blood pressure, or I need to give meds, or I need to listen to their chest. What do I need to do first? What do I need to think about? And that's that child's developmental level. Get on their level, and then you can do almost anything you want to these children. Kids are great, but you can't rush them. The nurse should expect the anterior fontanelle to close at this age. So we have an anterior and posterior fontanelle, soft spots in the child's head. And I'm putting this out there because this is one thing that we check. What if they close too early? What if they don't close? What does that mean? What should we do? We need to call the doctor. It could be closed too quick or still open. Is it hydrocephalus? Is there a brain tumor? What's going on? So the anterior is 12 to 18 months, okay? And that's why we measure head circumferences too, looking for maybe increased pressure in the head. What 2-year-old child pain assessment tool should the nurse use? 2-year-old.
Pay scale? The no more pay scale?
No. We don't use FACES scale until they're 3 years old, okay? And this is a common question I have seen. So it's FLAC up to age 3, and at 3 we can use FACES. This is your book, okay? I'm not saying that a younger child would not be able to use it, but the book says FLAC tool to their age 3 and then FACES scale, okay? At 6 months old, an infant's birth weight should do what? So at 6 months, it should double, triple at 1 year. Good. And if it's not there, why? Is it too little, too much? What intervention do we need to do? Cut back on food or add more? The first expected fine motor developmental milestones for an infant begins with. Now there's fine and gross motor development in children. So as you're reading, fine means fingers. Gross means get up and go, 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 movement, okay? Fine is fingers. What should they be able to do? The first thing is an infant. And you're gonna hear a mother say, oh, look, my baby just hugged my fingers, giving me a hug. It's a reflex. Now, I wouldn't tell them that, but it's a reflex. Starts with reflex, then it goes to palmar, then it goes into crude. Pincer grasp, which is this, getting Cheerios off the high chair, but usually it's like a smush first, and then it goes into here. Then it's putting objects into a container, and then it's building a block of 2. These are things you need to know. That's why this is here. It's a concept you will see repeated. At 8 months old, an infant should be expected to perform which fine motor skills? F, fine, fingers. And as you do your reading and I send you the PowerPoint, you're going to see there are outlines that, show about the fine motor and the gross motors and what they should do. So by 8 months, they should get that rattle, which is a voluntary, and they can actually do hand to hand by that. And then the crude pincer, which is, you know, smushing and getting those puffs or those Cheerios into the mouth. The natural physical developmental sequence that most children follow is what? What do they do first? What do they do second? I've mentioned it several times in this class. Physical, what do they do? First thing they do is lift their head. So that was easy here. Lift their head, roll over by 6 months, creep, crawl, cruise, and walk. Good. Now, it doesn't mean if a child's not walking by 1 year, like the book says, doesn't mean that they are behind. It just means they're slower, as long as they're moving forward. My grandson didn't ever walk. He ran at 15 months. And before that, it wasn't walking. And both my children did the same thing. Frequent developmental assessments are important for which reason? Again, so again, we are not going in the right direction. They're not being able to do things. We need to tell the physician and order early intervention. Find out why. Why aren't they where they should be? And this is how we catch things early and institute an intervention. And then again, these children catch up quick. Which behavior indicates that an infant has developed object permanence? Object permanence. Where is that rattle? So they actively search for something that's hidden because they've seen it, they know it's there, so they go looking. So that's part of cognition, that's awareness, that's growth. In general, an infant should triple their birth weight at what months of age? Well, we know we double at 6 months. When do they triple? And what do we do if they haven't tripled by then? Or they're way more than that? There are interventions for both of those. And it's 12 months old, they should triple. Again, these are markers that we look at because we can institute early interventions. Which intervention is contraindicated for a toddler? Now, a toddler ages 1 to 3. These are just becoming potty trained. They're just starting to learn how to maybe put on their underwear or something after they go to bathroom. What wouldn't you do? And that's, we are not going to make them be neat, okay? Or, you know, if they get a shirt on or a pants on inside out and backwards, we're going to applaud them for the attempt. Just because it's not the right way, it doesn't matter. It's the attempt, okay? Make sense? An RN is assessing a 2.5-year-old toddler should report which of these findings to the provider? I mean, these are when you're doing your assessments, you're doing all these measurements, you're seeing something that just doesn't look right. You need to tell the doc. Of these, which is not right? And that means your head at birth is huge. It's bigger than your chest, okay? You learned that in OB. As they get to be about 2, they should be equal or the head should be less than the chest. If not, tell the doctor. Why? Well, the head's too big. Why is it too big? Hydrocephalus, brain tumor, what's going on? Something's not right and we need to find out. That's why we do these developmental things. Which is the best approach when preparing a toddler for a procedure? You need to take a kid and take them for an x-ray, or you need to start an IV. What would you do? I mean, you're going to be on their developmental level for sure. That's always number one. But then what are other things you can do so that they're not going to be as afraid? And that's show them a doll, show them what it's going to look like. Let them touch the equipment, let them feel it, let them know what's going to happen, have them participate in it. And I'm telling you, children, even young 2- and 3-year-olds, are so much better and calmer when they know what's happening and they're familiar with the equipment. Perform a head to toe on a toddler. Most important to consider before beginning the examination. Again, toddler is a 1- to 3-year-old. First thing you're going to do. And you are going to make sure that you are preparing this child on their developmental level. That's number one. Prepare it on their level, describe those things. Then you're going to show them on a doll or explain it to them. And then you can do a procedure on a child. It takes time, but I'm telling you, it's better than a screaming child you have to hold down. I can't stand doing that. An RN expects that a child at 6 months of age, developmental status, will be able to do what? At 6 months old, these children, remember, they're going to hold their head up, turn front to back, back to front. They're going to get on their knees. They're going to start creeping. Then they're going to cruise, and then they're going to walk. What at 6 months should they do? And it's when they should be able to roll over completely. Good job. According to Piaget, toddlers are in the blank developmental stage. What I tell you about what they do. And it's sensorimotor. Remember, toddlers like to touch in their mouth and play with it. And this is part of learning, understand, and become creative. That's what Piaget is, all about mental and learning how to do things, putting things together. Which intervention helps a hospitalized toddler feel a sense of control? You know, I think the hardest person to take on vacation is a toddler. Toddlers like to be in routines. They don't like to be in different places because they're, you know, so confused what's coming next. And you really need to follow their rituals. They are the children who need rituals. That is their comfort. They know what's coming next. And when it's not, that's when they get frustrated. All children reach developmental milestones at the same age? Do they? Absolutely not. They're all different, unique, and as long as they're moving forward, you know, hitting those milestones, we're okay. We're all different. Children are all different. Immunizations for a 4-month-old infant. Which action should the nurse take to provide atraumatic care? Atraumatic care for an infant. What did I talk about infants? My grandson was circumcised this way. And that is the little bit of sugar on that pacifier and that self-comforting, and they do really, really well. It's like morphine, according to those Harvard guys. Which of the following immunizations can be administered to a newborn? One immunization is usually given prior to them leaving the hospitals, or at least on the first visit to the pediatrician. And that's your hepatitis B. As you read, you'll see it. And you're going to look at the immunizations like crazy. I'm going to show you what you need to know about them. Don't go crazy trying to figure out what's given. You know, immunizations 2, 4, 6 months, and 15 months. We're going to go over that. The normal heart rate for an infant is I said it a couple times. (140 to 160, and their respiratory rate is 40 to 60, normal. And this is an infant at sleep. A 2-month-old infant has cradle cap. What should the nurse tell the parents to do to treat it? That's that crusty white stuff on top of their head. Some infants have it, some don't. And what we do is just wash it normally, soap and water. Some of them say mineral oil, but just gently brush or comb it, and eventually it does come off. What is the preferred site to give an injection to an infant? Remember farm? And it's your vastus lataris, which is the upper outer thigh for sure. And last question. The death of an infant under 1-year-old with no known cause is called what? Sudden infant death, SIDS. Very good, guys. Let's see how we did today. Number 3, Erica. Good job. Number 2, Sean. Number 1, it's pretty good for really not knowing a lot of the information, Jessica. Number 4, Ray and Angel. Good job, guys. What I want you to do is sign your attestations, please. Get that done so you don't forget you were here, you did a good job. Is there anything you need from me tonight? Did you enjoy tonight's class? Or you're just
Hello,
really
Professor.
tired?
I'm
Tired now. I know, I understand. Remember, if you need anything, just let me know. I'm here to work with you. If you don't understand things, please let me know and I will help, okay? Nice meeting you all. Have a good night. Thanks for being patient. I did a couple minutes over. Not too bad.
Thank you.
No, thank you.